Hello there, I'm Benjamin. I'm just going to start with this. This should not be a replacement for standard studying. This will just be kind of a way to assist you in figuring out if you've got problem areas, if so, what you need to study, and just kind of helping you get a better understanding, because it's better to hear something multiple times than just hear it once, especially with faster courses in emergency medicine. This is more for the EMT basic level. It's not a very advanced delve into any of this. I will release videos that are more in depth, but they will have nothing more advanced than your basic EMT knowledge. Um, so let's delve in to the anatomy of your circulatory system, right? And just to start, the reason why I'm going over anatomy is because we're dealing with neurological emergencies, gastrointestinal emergencies, urological emergencies, and toxicology. So you just kind of have to review your anatomy so that it's just engraved in your head so that you know what you're talking about when it comes to everything, right? So let's go into the anatomy of the circulatory system. So I'm going to start with a pretty simple drawing because for a lot of people, you view the cycle of the cardiopulmonary system and you're sitting there like, oh, fuck, I really don't get that, you know? Because it is complicated. It doesn't make a whole lot of sense to some people, you know? So let's get our little stick man right here, right? This is your body. You've got a happy body because right now you are healthy. The physiology of your body is bueno. There is nothing going wrong. You're a good guy right now, right? Then you got your heart. I know, third grade drawn. And you got your lungs, right? So what we're going to divide the heart into is the right and left. So right will always refer to your patient's right and left will always refer to your patient's left. So what's going to happen here is the body is going to bring all that blood that it's been using that's deoxygenated into your right atrium, right? Your right atrium is going to go through your tricuspid valve, right? And then it's going to go with your pulmonary arteries into your lungs, right? And obviously it has to go through right atrium, right ventricle, and then it goes into your pulmonary valve. Pulmonary valve brings it to your lungs, right? Your lungs, it goes from your arteries to your alveoli, and then to your capillaries. Your capillaries get oxygenated through diffusion. Diffusion is a pretty simple process. It's basically nature's homeostasis, right? You got oxygen-rich alveoli full of all that O2, and your body's like, well, shit, I want some O2. And then all that O2 in the alveoli go into your capillaries. Your capillaries get that oxygen into your blood, and now you got oxygenated blood. Now the oxygenated blood goes into your veins. Your veins bring it right back into your left ventricle, or left atrium, right? So it comes in, it goes to your mitral valve into your left ventricle, right? So your left ventricle then pumps it out back into your body. And it is a nice little process that just keeps going and keeps circulating. This is regulated through your SA node. I will dive more into that in the anatomy portions, but all you really need to know, SA valve going good. You know, there's no ventricular fibrillation, which is basically your SA node kind of got off its fucking rocker, and then you got your Purkinje fibers and all of them just going, fuck it, let's go. It's basically like a chicken with its head cut off. Everything's working right, but it's not lead. So it ends up just going nowhere, right? And it causes more damage. And that is one of the shockable rhythms that I will discuss in the cardiac portion. Um, so yeah. Now, since we've got a basic understanding, right? What we're going to go into is the portion, or no, I don't want to delete that. We're going to go into the portion that is drawn by someone who actually knows how to draw, because that is not atomically correct. So as you'll see here, the left, since it goes into your arteries, and your arteries are driven by pressure. Pressure is how your arteries go, whereas your veins are driven by valves, okay? So your arteries have a very high pressure system, and the way that is regulated is through the big strong muscles in the left ventricle, and that just pumps all that blood right back in there, and it's a very strong muscle, and as you'll see in this diagram right here, it is a very big muscle. So let's kind of go over how this whole process occurs again, just this time using all the using all the terminology, right? So right here, would go down, right? Comes through your right atrium, down your tricuspid valve, into your pulmonary, then to your right ventricle, then into your pulmonary arteries. Your pulmonary arteries pump it into your lungs, and then that comes right back into your left. Um, then the left atrium goes through your left mitral, then to your left ventricle, then to your aortic valve. The big things you really have to remember here is more to do with like physiology, because a left-sided failure of your heart, left congestive heart failure, will result in normally some sort of buildup of the lungs, whereas the right side will result in what you'll see like the plantar edemas, where they've got these big swollen feet and they're all nasty, and you want nothing to do with it because it gets blood all over the place. It's not a very good way. Um, so next we're going to go into your anatomy of your vessels. So the vessels are pretty simple, at least for EMT knowledge, because all you really need to know is artery is a smooth muscled cell that is similar to the vein basically, and it's a pressure system, so it's based off muscles, and as you can see in the diagram, the vein has its little valve. So a big thing that you really need to take from this is your lumen, because a lot of this will be discussing things like atherosclerosis, I think it's called, which is basically plaque buildup in your veins. There are many other things that can happen also, like the hardening of the veins and all that kind of stuff. The big one we're looking at is plaque, because that will apply a lot more to your neurological and your, yeah. So let's move into our anatomy of the brain. So as you'll hear here is your dura. The dura, we'll go into that when we get to the neurological side, but it's pretty simple. The big things you really have to remember is your skull, your dura, and then you got your sorry. The big word is the cerebellum, and then you got, my notes are right here, sorry. Your cerebrum. God, I'm fucking tired. I should probably chug a little bit more coffee. And then you got your brain stem, which is right next to your spinal cord. And then you've got your forma magnum, which is that little opening right there that lets all that shit come out. And we'll discuss that once we get into the hemorrhaging strokes and the ICPs, because because that will start making a whole lot more sense why we're talking about that. So first things we're going to get into is physiology. So the big things you got to remember are obviously your receptors and how they respond. So you got your like alpha receptor, which will dilate vessels, get oxygen ready to move through them. Your blood vessels, obviously. And then we've got your Pt.1, which will make your heart rate come up, all that good stuff. You got your Pt.2, which dilates your bronchi, which gets that O2 moving. Epinephrine normally stimulates your heart, whereas norepinephrine stimulates your vessels. Your sympathetic will be your fight or flight. That will be the one that you see a scary dog barking at you, you're like, oh shit, time to get out of here. That's the way you view that one. Your parasympathetic is your rest and digest. Or, there's a couple other ones, but I'm not really going to get into those. So, yeah. The big things you need to remember when it comes to terminology, especially when we're discussing this unit, is your hypo, hyper, brady, and tachy. Hypo being below normal or low, hyper being above normal high, brady being below normal slow, tachy being above normal fast, right? So you got your hypotension, that's where you've got the dilations of your blood vessels, which can cause a lot of problems, and you got your hypertension, which is the constriction. Bradycardia is a slower heart rate than normal, and bradycardia is your above normal. So what I'm going to do right now is I'm going to kind of show you, the basics of the system, right? Sorry. So what we're going to go here to is we're going to go and we're going to have your vessel. So this is your normal vessel, right? So you've got your heart rate, which is 100 to 60. I think it might be 100 to 80. I'll go over that and I'll correct it afterwards. Then we got your systolic, 120 over 80. Your diastolic and your systolic right here. Your systolic being the top one, that's when your vein or your arteries are at pressure. 80 being your diastolic when your arteries are not at pressure. Okay, so that's your normal one. Not too big. It's normal. It's like a bucket. This is your container, right? So you got your 5 liters of blood right here. It fits this little container perfectly. It's enough to keep it moving around. So then what happens with hypotension, which is when you see, like say someone was taking a sexually enhancing drug like Viagra, and then they took nitroglycerin, right? Now, that's very bad. You don't want that. That's a very big contraindication right there, and that can lead to very big problems, which I'm going to show here. So then you've got your hypotension, right? Hypotension is going to be, that like, fuck. You can see it sometimes. It's like that 60 systolic, and you got like bare fucking bones systolic, right? Very bad. That's, that crazy bad. Someone's crashing shock kind of stuff, cardiogenic shock kind of stuff right here. These are those really bad numbers you never want to see. You can also see it with like a 90 over like 60, right? Just not good, So this very big. So your container now is, instead of a 5-liter container, it's now a 10-liter container. It's a very big container. So now you got all that fluid right down here, that 5 liters of fluid, and it just doesn't fill up, and it's a very bad deal for everyone involved. This and treating this is all ALS, because you can't really give medications that isn't prescribed to the patient, especially in California. Other states it might be different, and you might have a lot more scope of practice, but here the scope of practice is generally you can only assist in administration. The only things you can really do is like aspirin if it's cardiac origin. That's about it. But you don't really carry meds on ambulances, so you're kind of just praying ALS gets there quickly. So yeah, if that makes sense, hopefully it does. So yeah. Oh no, I don't know why I'm so obsessed with closing that right now. So yeah, that hopefully makes sense. Bradycardia will be, or slow heart rates. Those people below 60, you're having problems. Generally, a big thing that you need to look out for as an EMT, especially when you're getting into the field, is signs and symptoms. That will be your way of determining everything. Because if someone's got a low heart rate, but they're a runner, they're a really healthy person, their, body is good, their cap refill's perfect, everything's good, you might be more inclined to see a lower blood pressure that makes sense for them, and it's not going to be alarming. Because I was talking to somebody, and they said, like, in one of the places they worked, you would see people with like a 90 over 60, and that would be completely healthy for them. It wasn't alarming. They were small people, and they were pretty healthy people, and also, in the contrary, you might see a chronically hypertensive patient who they've got an alarmingly high, but it can be regulated through medication, and their body gets used to it. So you just got to be aware of that. Your signs and symptoms, obviously, being is if they're cool, if they're clammy, if they're sweaty. The diaphoretic patients, your cyanotic patients, all those people, that is a sign of fucking poor perfusion. You want to get them O2, you want to get them things. That goes back to your ABCs, all that good stuff, right? So next, what we're going to move on to is cerebral vascular accidents and or strokes. So strokes are the 5th leading cause of all deaths in America, and the big things you got to kind of remember here are the risk groups. So this has nothing to do with racism or anything. This is just statistics here. It's evolution, whatever. It's just things we can't really control. So you'll see patients who are Hispanic, African American, and Asian being more likely for strokes than per se like Caucasian, right? Um, so the big things you got to remember here are, your general pathology and how things work. Your O2, glucose, and temperature are going to be your big regulators here of your body, and they always are. Um, the big ways that you can tell things that are related to your strokes are generally consciousness, speeches, and voluntary muscle control. So let's start moving into the differences between hemorrhage and non-hemorrhage. So ischemia will be what you'll generally see with both of these. It's a reduction in blood flow to your brain cells, right? Well, it's inadequate O2 being supplied to your brain cells, sorry. So we're going to get into um, ischemic strokes, which will generally be your like blockages. That's your non-hemorrhage, right? That's 80% of the cases you'll be seeing, right? So the things that cause those will be your thrombuses, which is a clot that's formed on site. So that will be your arterial sclerosis, and that's basically all that plaque builds up from bad habits, age, all that good stuff, and eventually there's just no way that your body can get through it, and so it just closes up, and there you are. You got a lack of supply of O2, lack of supply of blood, no movement, no good. Then you got your embolus, which is your clot that forms remotely, then moves onto site, right? So, like a big thing you'll see this in is like your pulmonary edemas, right? With a CHF patient, they'll have this free floating little shit that gets popped up and it gets caught in your capillaries or something, and that's right there. You got blood coming into the lungs, no good. The patient's not doing too hot, right? So next, we're going to be moving on to the more hemorrhage side of things. So a big one that you'll see, so this is about 13% of strokes you'll see in this. There are things like heat stroke and all that good stuff, which goes back to temperature, which I was speaking to you guys about. So what we'll see is a berry aneurysm. Berry aneurysm is basically a jutting of your artery. So when you get older, or with some people who have it hereditary, genetically, their body will just naturally have weaker linings in the arteries up in your brain, and these will form these things called berry aneurysms. And the big, easiest way to remember an aneurysm is something that hasn't popped, and dissecting is popped. So your aneurysm will be this good old little balloon-like object that is from the malformation of the arteries, and that will allow for popping, which can be life-threatening. So the big things you got to remember with hemorrhage is it's not going to be the blood that kills them, because there's not a lot of room for them to bleed out. So like a pop of your berry, for example, will end up being more to do with your ICP, your intracranial pressure, than anything else. Because you got to remember, 100 millimeters of blood might not seem extreme if it's a traumatic event, right? But when that's in your brain, where there's so much fluid already, to prevent concussions and any sort of other damage, it ends up being a very bad thing. So next we're going to move into your transient ischemic attacks. That's going to be, it's kind of like an angina when you're speaking to cardiac problems. So it is it's basically like a pre-shock to an earthquake. It's like something bad's about to fucking happen, but it isn't happening yet. They're also known as mini strokes. Basically, 1/3 of people that have a TIA are going to have the big one, the stroke, right? And when you have a TIA, you might not have to treat them like a stroke, but it is good to get them to a doctor, get them to a specialist, take them to a stroke center so they can get that treatment and they can get that help, because it's more than not going to end up being a stroke at some point, right? So next we're going to move into what happens, what are the different effects from strokes in different portions of the brain. So if you have a stroke in the left portion of your brain, the left hemisphere, that will result in the right body having problems moving. You know, you won't be able to move the right portion of your body as well. That will be like that facial droop, the inability to hold that part up. You'll have aphasia. So they might be, they might not just be able to speak or understand it. You know, just completely gone. Or it'll be they can have some speech, but it's just very like poor, and it seems like they have no understanding of what you're saying. Like you can ask them what day it is, and they'll be saying shit like green. So that's generally your left-sided failures. Then you've got your right-sided, which will be your left body failure, and that will be the inability to move the left portion of your body. Um, they can understand and speak, but they generally have a slurred or hard to understand pronunciation of words. So that's the way you kind of see that one coming out. So, yeah. Um, Now, you gotta remember the things that look like strokes but are not strokes. This is a very big thing to remember here. So, you've got things like hypoglycemia, which we'll also be discussing in the stroke portion. But hypoglycemia can almost seem like exactly like a stroke, but it might have nothing to do with a stroke. It's simply the lack of glucose in the body, right? So that will be your or below average glucose in the body, right? Um, so yeah. Next, we'll have our like postictal state, which we'll go over in seizures more, and then subdural and epidural bleeding or trauma. So with your subdural, you have your dura. Your dura is what separates your skull from your brain. Your epi will be the outside. That will generally be from a I got it right here. It's a medial. It's a middle medial artery, and a fracture that causes damage to that will lead into bleeding in your epidural. Your middural will be inside the dural, so that will be bleeding inside of the dura, which will be making contact with the brain. So the way you kind of can remember it is epi, it's away from the brain. Sub will be with the brain, So another big thing here, since we're discussing strokes, the Cincinnati Stroke Scale. This will be your good way of determining if someone has or has not had a stroke. So the big things you'll be looking for is slurred speech. If someone has a slurred speech and they have a problem speaking, or it's very, hard to understand them, that's one mark. That's not good. And you've got smiling or baring teeth. If there's a facial droop, that's another mark. Arm drift. So if you hold both arms up and tell them to hold it, and they close their eyes, whatever, and they can't hold it, that will generally be a pretty good sign. Those three are your main focuses. If you don't remember shit, those three you need to remember. Next are grips. So you can ask the patient to grip your hand or arm, and they'll squeeze, and one hand will squeeze harder than the other. This one you got to pay attention to because this will also probably be the one that's drifting. The same with the gas pedal. So if you have these three and they're all the same, that's generally a pretty good sign of what kind of thing you're dealing with there, Then we got flex. Flex, same deal. It's the flexing of the muscle if they have problems, etc. Holding up the legs, it's very similar to the arm drift. The legs come up and you can't hold them. Yeah. Your pupils, they tend to be very, you'll have one pupil that might be constantly dilated, or one pupil might dilate more than the other. Um, you know, they might have a very poor balance. If they're sitting up and they keep leaning to one side or whatever. The big thing you got to remember is medical history when you're dealing with stroke patients, because a lot of strokes will be these older folks, in their late 50s. They're older geriatric patients, so this might be normal for them, and you don't want to go jumping around saying someone's got a stroke and they don't. It's good to always err on the side of safety, but talk to their primary caregivers, talk to the people around them, figure out what their normal is, what their baseline is, because generally someone who's around that patient long enough, they'll pick up on their things, and if they're calling you, it's generally going to be because they're acting abnormal, but there's also a good chance that it might have nothing to do with it, right? So, another thing is headaches. So a headache is a phenomenal symptom because that will either tell you got a stroke or you don't got a stroke at times. and that could really help save a life, and it could also, just be a headache, because headaches are a very common call, and you got to remember that. Um, so with like the berry clusters, those can present with headaches occasionally, and that could be something that's very important to pick up on. So the big things you got to look up is your red flags, man. There are things in this world that you see. It's like that crazy bitch at the bar, She's, flirting with so and so, and he's just eating it all up, but she's being a psycho bitch, You're like, oh, I don't want to touch that, 6 foot stick, you know. So you got to look at the rapid onset. If it's something is acute and it's brand new, it's not chronic, and it's a headache related, that is not good. You don't want that. That's very bad. If you got an explosive or thunderclap pain, I will be discussing headaches here briefly, but you'll notice that you will not be hearing terms like explosive and thunderclap. Those are very distinctive, hard, bad pains, Or altered mental status. Like mental statuses that just, it's like someone who's been drinking or something, an altered mental status. You'll see it, you'll understand it. Age is 50 and above. 50 and above is that nice little age point once your body starts really decaying and those things start coming around, The immunocompromised, so people with like HIV, AIDS, those kinds of people, those will be people you'll see. People who run risk groups like smokers or people who are chronically hypertensive, Those kinds of folks. Infections will be another one. Neurological defects, it's just chronic, this hereditary, that kind of stuff. Fevers will be another good one to look out for. Um, like, yeah. So we're gonna go over headaches right now. So headaches are a common complaint. You'll run on these calls pretty often. It's gonna be like abdominal pain, chest pain, that kind of stuff. That's all very common calls. So your tension, these will generally be your older guys, older women. They're fucking stressed, overworked. They're all tired. It's that dull, achy pain. It's everyone's probably had one. And what you gotta just do is put them in a position of comfort, give them a little low too, and normally that headache's gonna go away. Um, that'll generally be how you can tell that one away. Your migraines will be from changes in sizes at the base of the skull, or that kind of stuff. It's very it can be very bad for some people. A lot of people describe migraines as very difficult to deal with, and a migraine tends to be more chronic. So you got like a 25-year-old who's like complaining of this, and they've never had a migraine. You might want to start looking towards like other causes, because someone who's just randomly had one and it's not a chronic issue, that's not a good deal, And that's when you might come back to your like EPI or your epidurals and all that kind of stuff. Next up, that'll be like that sharp, pulsing, throbbing pain. It'll also have like nausea, vomiting. It can be several hours to days, of this. You want to keep them in a low light environment. You want to give them low flow O2, like a nasal cannula, and just a position of comfort. Some of these people, if it's acute, it's new, you might as well just take them to the hospital because a lot of these people are on medications for these exact reasons. Next, we've got sinus, which is pressure from the sinus, and these can lead to infection. So it's kind of just, look out for those antibiotics. Be careful around these people. Just make sure they're good because those are, it always kind of sucks having a headache. Um, so next up, we're going to be moving on to our seizures. So seizures are basically when your body has a right here overstimulation, understimulation, or surge of electricity to a large area of the brain. So overstimulation can be like our epileptic patients who are like seeing flashing lights and they're not taking their meds, or just some sort of overstimulation, that just all of a sudden sends them right into that seizure. Or understimulation, this can be your hypoglycemia, your hypoxic patients. There's a lot of different reasons for that. Or your hypothermic. There's a lot of things that can present due to understimulation. So next up will be things like unconsciousness. So when you're dealing with a general tonic-clonic or like it's all kind of the same thing. Tonic, clonic, generalized, same shit, right? You might hear it as a grand mal, that kind of stuff. So tonic will mean you're stiffening, and clonic will mean twitching or jerking. It's a rhythmic motion, and it is a full overstimulation of the brain. This will be a full body issue. It's kind of, I guess, the ones that Hollywood will probably aim after, like that. Just whole body's going, It's rhythmic. So with this, you'll have some patients who have auras before these, and they'll see, like, or smell, or they'll have something that shows them what they're going to be experiencing a seizure. And the postictal state happens after every seizure. So, the big way to remember a postictal state is it's like your brain rebooting. So after you just had this massive exertion of energy, because you got to remember, like, when someone's having a seizure, you just need to clear them out, make sure they're not hurting themselves, obviously, but, clear the area, let them seize, because with the seizure, the big thing is they're going to be overexerting the shit out of their body, and it's going to do a lot of damage if you decide, oh, I'm going to hold their neck, because you hold their neck, their body is putting so much fucking force, it's like all this body pressure going into this, and it can be very bad, really bad, if you try and stop it. So that's why you kind of just let them seize, and you deal with the symptoms afterwards. The postictal state is your body recovering. It's going to have that deep, labored breathing, that like, like, someone really breathing in that air because they're trying to recover. It's like running a mile or something, because it's that overexertion of your body. That's also to prevent that, buildup of toxins, because your body just put a lot of effort into that. So yeah. So next we're going to go into partial or focal. So the partial and focal are categorized in two different ones, simple and complex. It is a part overstimulation of the brain, right? So with the simple, what you'll see is more of a like numb, weak, dizzy. They might have visual changes, unusual smells or taste, twitching of muscles, and extremities that slowly spread from one side to the other, and brief paralysis. Now, you might not see all of these symptoms or, certain symptoms, but generally that's going to be a sign of your simple partial seizures or a focal seizure. Next will be your complex complex partial seizures. So that will be your altered mental status, your abdominal abnormal discharge from the temporal lobe. This will result in like your lip smacking, your eye blinking, your isolated convulsions and jerking, unpleasant smells and hallucinations, uncontrollable fear and repeated behavior. So you'll see someone like sitting and standing. You might not, as I said, with the simple, you might not get all these symptoms, but you'll get a good chunk of them. So if you're dealing with an unconscious patient with like your generalized seizure, your tonic-clonic, they will lose control of things like their bladder, and like defecation. So incontinence will be a pretty good way of determining things like that. Also, like breathing patterns, that kind of stuff. A big thing with seizure patients is kind of really just treating the symptoms as they go along, because what you really need to do is get them to a place where they can get neurological help. Because if this is a chronic issue, they'll probably be fine, but if they're not taking meds or something, it's better off to get them to a doctor or someone who can help them, a specialist who knows what they're talking about, right? An acute is it's bad, you don't want acute seizures because that's new. It might be brand new for the patient, this might be a younger patient, but if it's an older patient, it's like related to trauma or something, that's bad, you want to get them to a neurological specialist so that they can get help. So a lot of the things you'll see with your generalized seizures will be tachycardia, hyperventilation, sweating, intense salivation. Now, you might not get all of this, you might not get any of it, but these are generally your symptoms of the event, right? So if it's more than 5 minutes, you're generally going to be seeing a status epilepticus. So you're generally going to want to call ALS if it's more than 5 minutes, because an epileptic who's not taking their medications can be, though maybe chronic, it can be very dangerous for the patient because 15 to 30, sorry, can be very, very bad. So the four major causes that you'll see of seizures are going to be your epileptic, which is your congenital origin, your structural, which will be your tumor, infection, scar tissue from trauma. Your metabolic will be your like hypoxia, abnormal blood chemical, hypoglycemia, OD, poisoning, sudden withdrawal from like alcohol or drugs. And then your forbile, febrile, which are sudden high fevers, like someone going from their average, like a 98.7 all the way up to like 104. That kind of stuff will cause like those seizures. Like I was talking about with the um, your hypo and your hyperthermia, of that big temperature change. So your postictal, you'll generally be able to tell that by the labored breathing. Like I was talking to you earlier, it's that fast, deep breathing. The muscles are completely relaxed. They're flaccid and floppy. Like someone who's just kind of just out of it. Um, yeah. So the longer your seizures, you're gonna have those longer postictal states because your body is really trying to, return to a normal state, that homeostasis. A big thing is your hemiparalysis, which is paralysis of one side of the body. But this can recover with time, and that can be something that's alarmingly close to a stroke, and you want to be careful of. Um, so things like, so final parts of your neurological emergencies are going to be your hypoglycemia and your delirium. Delirium can present the symptoms of like severe schizophrenia, delusions, hallucinations. These like crazy things. This can be seen in older geriatric patients and stuff. It can also be seen in younger patients. That's something you gotta worry for, because those are obviously neurological calls, and there's probably it's not the disease. It's a symptom of a disease. It's not the end all be all. That's a sign, right? Um, and the hypoglycemia is more of a disease. But it can also be a sign at times. So you got to be careful and pay attention to what's going on. The big thing as an EMT is you're not diagnosing things. You're really just trying to get an idea of it so that you can give the doctors an idea of what you think is going on so that they can go in and they can get that CT scan. So that's why it's very important to be able to recognize a stroke. There are a few things in EMT field that you really need to have a good understanding of, and strokes, cardiac, and trauma are really your big things you need to have an understanding over, because if someone has a stroke, you need to get them to a certified stroke center. Those are the ways that they're going to get them, because they have the specialized doctors, they have the specialized people that will be there, that will have the training, that will know what to do. Because if you bring him to general like ER, this guy's having a stroke, he's not going to get the treatment he needs. So you've got to be able to recognize a stroke so that you have the fallback of ALS, obviously, but it's good to have the competency and the knowledge so that you can look to them and say, hey, I think it's a stroke. Here's why. This is their vitals. This is what's going on. Because that aims it in. That makes it quicker transport. So that if it is a stroke, they get that quicker treatment. And it's time is tissue. And with this kind of issue, it is really a matter of brain, because when you have lack of flow of oxygenated blood, that starts getting to the point where you're getting that brain death, that permanent, irreversible brain damage. And that's why CPR is important, all that stuff, right? I know I kind of went off on a tangent when we're talking about seizures, but yeah, the big thing we're moving on to next is our ABD. Sorry, acute abdominal pain. So if you're reading this in the forget the exact name of it, but it's what you're probably going to be reading if you're studying emergency medical stuff in 2020. I'll put a reading. I'll put the book's name down in the description. So what we're moving on to now is our gastrointestinal and urological emergencies, right? So we've got ABD, abdominal pain. You've got the abdominal cavity, which is full of solid and hollow organs, which, if traumatic events occur, can lead to bleeding and shock, which are very big events right there, right? So your liver will be a very solid organ, right? You know, I imagine a lot of you've seen livers, and they're, a hard organ, right? So with bile, you'll get secretion of you'll get secretion of bile, and it's kind of a reservoir for it. The liver also filters out toxins. It creates stores for glucose, and it produces clotting and immuno functions. Okay? Um, so yeah. And then you've got your pancreas. Your pancreas secretes enzymes that breaks down fats, uh, your starches, and your proteins, and it's responsible for bicarbonates and insulin, right? Another thing you got to look for is your large and small intestines, right? So there's also things like the gallbladder, obviously, your spleen, and your appendix. They have their separate functions, and they're all part of your abdominal cavity, which is all surrounded by your praetorium. But I'm gonna focus more on the things that we'll be talking about in the things that pertain to abdominal pain. Uh, Chapter 18 has an entire thing about um, referred pain. Sorry, and just pain in general for like symptoms and what's going on. And I would take a good look at that. That will be very helpful in learning. So a big thing you're gonna have to remember is like, your colon, because that's gonna be a lot of your GI bleeds are related to your large intestine and just your general GI tract in general. I'll be talking about that once I get to that portion. Your colon is responsible. It's also known as your large intestine for food breaking down. That's what creates your poop and your water. Your small intestine's obviously what's absorbing your nutrients and all that good stuff. And your stomach will be breaking down a lot of that stuff. So what we're going to look at right now is your peritoneum, which the partial lines the walls of your abdominal cavity, whereas the visceral lines the organs. And when blood, bile, or pus gets into them, that's when you'll see symptoms like peritonitis, which is inflammation of your peritoneum, which can result and or cause ileus, which is paralysis of muscles that propel your material through your intestinal tract, right? So you got to remember this. So your peritoneum is very close to a lot of your body out there, and the peritoneum also has a lot of nerves in it. So that can cause a lot of very visceral bad pain. So your or your partial will be like basically has the same nerves as the skin, so it feels all that kind of stuff. And you get your visceral, which is attached to your autonomic nervous system, which is your automatic, because attached to obviously your, food digesting stuff. That's part of your autonomic nervous system because you don't really control that. So things that will produce referred pain, the big ones you got to remember is your spleen, which will be your like left shoulder, and your gallbladder, which will be your right shoulder. Those are the two easy ones to kind of just pick up on. So we got ulcers, which is the mucus lining of your organs erodes and allows acids to eat at organs. That can be a very painful deal. We got gallstones, which they form basically in your gallbladder, which can cause blockage, which will result in inflammation or a problem called cellulitis, and that's basically inflammation in the gallbladder. That can lead to it rupturing, which can result in a lot of bad things. Uh, yeah. So next, we'll be moving on to our pancreatitis, which is your inflammation of your pancreas. Your uh, appendicitis will be your inflammation of your appendix. Your gastrointestinal hemorrhaging, which will be acute or chronic. But the big things you got to remember is your upper GI bleeds. When it's coming out through stool, it'll be a dark tar-looking substance, and if it's a lower GI bleed, that will be your more bright red bleeding. So the big thing you gotta pick up there too is that was when it's coming out through your stool. It's the opposite when it's coming out through throw up. So if you've got that bright red and it's coming out through throw up, that will be your upper GI. But now if it's a darker tarry, more tarry substance, that will be your lower GI through throw up. All right. So you've got your esophagitis, which is inflammation of the esophagus. This can come from GERD, alcohol, and drugs. So then you've got esophageal varices. I don't know how to pronounce that, and it's really fucking rare. Um, and that's pressure within the blood vessels surrounding the esophagus, like vessels basically, lining. So then we've got Mallory-Mysis syndrome, which is the junction between the esophagus and the stomach, tears causing severe bleeding. That's another pretty rare one. Then we've got your gastroenteritis, which is an infection from bacterial or viral caused by non-infectious conditions. Then you've got your diverticulitis, which is fecal matter building up in the colon due to little areas causing inflammation and infection. That can be very severe. Then you got hemorrhoids, which is swelling or inflammation of blood vessels or rectum. Then we've got cysts, cystitis, which is basically a UTI or bladder infection. So next up, we got your kidneys. You got kidney stones, which are deposits. And any sort of stones is like a buildup of things that aren't supposed to really be building up. So if your kidney is failing, you'll see things like urema, which is like just a bad urine. You don't really want to see that, you know. So kidney failure, if it's acute, will result in a sudden decrease in kidney function. This is normally resulting with trauma, ODs, or infection. This is reversible with prompt diagnosis and treatment. Chronic will be your progressive, irreversible damage that eventually will result in dialysis. Chronic is more older folks, and acute will tend to be your more, like overdosey patients, right? So the female reproductive, that's a completely different chapter, and I sure as shit ain't a specialist in that, so you're gonna have to revert to that chapter. That's more of those gyno problems right there. So another thing you gotta remember is your AAA, which will be your um, aortic aneurysm. Fuck. Yeah, basically, what happens is there's an aneurysm on your aortic artery that is caused by your peritoneum, and it basically just keeps inflaming. And when that dissects, that can be a very big problem. So you got to use extreme caution if you assume or you've detected a AAA. Because if that thing ruptures, that's your aortic. It doesn't matter if you've got a team of surgeons. By the time they figure out that bleed, right, or a team of surgeons right next to you, by the time they figure out that bleed, you're probably fucking dead. It's very hard to detect, as is. So it is pretty good if you suspect this, AAA, to just be very careful. So just one more thing to go relapse over is ileus. That will be that paralysis of the muscles that move the body through, right? That's very, very important to remember because things like pneumonia can cause that and abdominal pain. Hernias is basically a protrusion of organs into a body cavity where they do not belong. Like, it's normally a noticeable mass, and yeah. If you can push it back in, generally that's okay. You still want to obviously get them back to a doctor, but that's a little bit better. But if you cannot push it back in and it is cut off, that is a serious problem. So, cystaginolium, I think, is the technical word that you'll use. No, sorry, that is in a carcerated hernia, which it cannot be pushed back in. And it is bad if you hear it is pain, it's tender, it's red or blue discoloration near it, or It's just not reducible, right? Um, yeah. Some big things to also remember is scene safety. It's always going to be something you need to go over whenever you're talking about these things, especially when figuring out what's going on, especially with ABD, because that can help you determine what's going on exactly. So next, we're moving into toxicology, right? We've got your uppers, which are like your amphetamines, those people do that kind of shit, right? Um, Obviously, refer to chapter 21 because they have an entire chart about all these drugs and how they all work. But as I said, it's a brief synopsis. It's just trying to figure out what you guys got troubles in so you guys can go on to further videos that will have in-depth, more accurate, quality information. So, downers. So, uppers, you're going to see your more tacky, more pinpoint problems, that kind of stuff. You're going to see like pinpoint eyeballs, that kind of shit. That excites the CNS. Whereas downers depress the CNS. So you'll see those more Brady um, issues. So we've got antichlorhidic, which is basically it blocks the parasympathetic, whereas chlorhidric's excited. So it's also known as organic phosphate poisoning. Big things you got to remember here is SOGM, which is salivation, uh, tears. I don't know how to say that. Urination, defecation, um, gastrointestinal, um, emesis, which is throw up, and meiosis. So you got to figure out what they took, when they took it, how much they took, what they ate last, if they've taken an antidote, and their weight. That will generally help you out, especially when it comes to things like workplace accidents. Because a person who's standing right next to a workplace spill, that's bad. Someone who's standing far away, not as bad. Especially when it comes down to triaging. So the four ways that you can ingest something is inhalation, absorption, ingestion, and injection. Um, so just quick pro quo here. If you hear things like codone or codeine, you're going to want to assume that you're good old narcotics. But so the history of exposure, that's a pretty good one. If it's a liquid, you want to put water on it so it can wash out those burns. If it's a powder, you do not want to wash it off necessarily. You want to brush it off, then wash it off. That's your important thing right there. So if you hear things like burning, itching, irritation, odors, any of that kind of stuff, you see that kind of stuff, that's always going to be stuff you want to pay attention to. Just a quick thing, things like hydrofluoric acid, that's bad news. You don't want nothing to do with that, right? Um, Next up, we've got how to really treat them. So you want to avoid contamination of yourself and your ambulance. So always decontaminate whenever you're dealing with environments. The book will tell you to take a sample of whatever ever so that they can know what's going on. I mean, honestly, you're not going to really be responsible for that as BLS, and if you are doing that, you're just going to contaminate more shit. You also want to remove clothes, irrigate the problem, and you want to just keep that clean, the book will say exact portions, but I'll go into that in a later portion. Big thing about industrial is you want to make sure there are safety showers and people are decontaminated, hazmat. Ensure, people are decontaminated. Obtain material data safety. That goes more to the fire department. That's not really your big deal. So yeah. So 80% of and that will be your absorption and inhalation right there. So a lot of your people who eat something, yeah, those people tend to be accidental as children and deliberate as teenagers and adults. You gotta look out for GI pain, burns around the mouth, like seizures. Um, you gotta treat signs and symptoms. That's more ALS's job. Activated charcoal is a way to treat it, but it's very primitive, and if you got ALS on scene, they're probably gonna tell you to fuck off. You want 1 gram per kilogram with a maximum of 50 grams. Um, IV drug abuse. That's another one. This goes back to that just treat the symptoms, because that's one of those ones that there's not a whole lot you can do. You can do with burns and absorption, but you can't really do a whole lot with that. Um, you really want to monitor airway and check for smells. Hydrogen sulfate, that's a bad one. Hydrogenized carbons, those are very bad solvents to deal with. Uh, these are more referring to like your symbiosis, that'll be your uppers, and then your synthetic cathasis, those will be your like drugs like bath salts. I know this is kind of getting chaotic here, but as I said, this is an overview, not as much a direct study. An acute OD is always bad. That'll be the things that you run into with like your seizures, your strokes, and your cardiac dysrhythmias and shit. So yeah, that's pretty much your overview of those three. I will be releasing videos that are more pinpoint and exact, teaching more terminology and diving deeper, but these are more your just general overviews over the subject. Hopefully this helped you. If you have any questions, any critiques, any problems with the information I gave, please tell me in the comments, because I don't want to be giving out misinformation. This is to be helping people to get ready for the FISDAP exam. So if you need help, obviously, go down to the comment section. There will be more information down there. Thank you for your time. I hope this was helpful. Have a great day.